Assalamu alaikum. Good evening, everybody. I would like to thank you, all of you, that you had attended this very important webinar. This webinar is under the umbrella of Saudi Society for the Clinical Chemistry and the Saudi Point of Care Testing Association, SPOCTA, in collaboration with Roche Diagnostics. This webinar, as you had, of course, all read, this title about controversy over different HbA1c as measured by different techniques. As you know, that diabetes is a growing epidemic that is reaching alarming levels. It's an impactful disease that threatens global health and affects a significant number of people worldwide. Today, nearly 500 million people in the world are living with diabetes, and this figure is only and expected to be raised by 51% until 2045 year. So, in the management of diabetes, actually the HbA1c measurement is the gold standard for the long-term follow-up of glycemic control, and it's complementary to the patients. So we will talk today by our speakers here. I would like to share with me to thank all of them that they had attended this meeting. As you know, that the HbA1c testing is confident to the patients. So fasting is not required prior to taking sample. The sample may be taken any time of day, and minimal preparation required by the patient, and there is not affected by acute factors. So that's why measuring the HbA1c considered as a gold standard for control of diabetic patients. And because of this importance of testing the HbA1c, we will talk also about the value of using the HbA1c instruments in a point of care situation to minimize the workflow in the main lab.
Assalamu alaikum. Is the screen obvious now?
That's clear. So yes, it's one.
Yeah. Okay. I'd like first to thank the organizing committee for giving me this opportunity to present with you here. I'm Dr. Abdulghani Al Said, consultant endocrinologist in Prince Sultan Military Medical City. Instead of talking all about hemoglobin A1c, I will talk about the challenges in diabetes diagnosis and monitoring, concentrating on the hemoglobin A1c. So no conflict of interest regarding any information in this lecture. So this is my outline. I'll start with a real case study, and then I'll give a brief introduction about why do we care about diabetes mellitus. Then we'll go to the most famous criteria for diagnosis of diabetes, which is the ADA criteria, which is the American Diabetes Association, and then hemoglobin A1c as a tool of diagnosis and monitoring, and lastly is monitoring glycemic target. So I'll start with this case presentation. So this boy was referred to me from primary health care. He's a 13-year-old boy. He was referred from primary health care after a diagnosis of type 2 diabetes. Upon checkup, he was found to have an hemoglobin A1c of 6.7. So the primary care physician started him on metformin, and he referred him to the diabetes center at the Prince Sultan Military Medical City. His mother didn't give him the medication, and she stated that there is no really family history of diabetes in both parent or sibling. He has only just a grandfather who has been diagnosed with type 2 diabetes after the age of 70 years. His finger stick random blood sugar at the primary health care was 5.9 millimole, and that was a random blood sugar. So when he presented to the clinic, a blood test was taken and showed This was a serum fasting blood sugar 4.7, so it was a normal, but the repeated hemoglobin A1c was again showing 6.5, so as if he's having diabetes. So the mother asked this question: does my child have diabetes mellitus? And I think we'll answer this question along as we go on with this presentation. So why do we care about diabetes mellitus? As rightly said by Dr. Anas, this is the IDF 2017 Atlas. The estimated number of patients with diabetes worldwide was 400 million, and we're expecting to exceed 700 million individuals affected with diabetes mellitus. So it's really just a very prevalent disease. And if you could see here, our country among the darkest color with the prevalence of diabetes, so it means that the prevalence is more than 12%. And if you look to the epidemiological study, the prevalence of diabetes in Saudi Arabia, unfortunately, over the last 4 decades, it increased by tenfold. And if we look to the real statistic here, in 1982, the prevalence of diabetes in one of the study in Saudi Arabia was 2.5, and now it reached in the last 2 studies, the first one was done by Nuzha in 2004 and by Dr. Rubi'an in 2014. It's almost 25%, so 1 out of 4 for individuals who are 30 years old or older. And Rubi'an, he also just included an overall prevalence from age of 0 to 100 to be 11.9%. So this is really a very high prevalence of diabetes mellitus. Why really, when we treat patients with diabetes, we have just 2 important aims. The first aim is to prolong life expectancy, and this is done by preventing the macrovascular complication of diabetes, which is mainly stroke, heart disease, or peripheral artery disease, and to improve the quality of life by preventing the microvascular complication, which are the cause of morbidity like blindness, limb amputation, or chronic kidney disease. Unfortunately, diabetes is the one which is associated with all of these complications. So what is the criteria? How to diagnose the diabetes mellitus? This is the most famous criteria which is used worldwide. It is updated yearly by the American Diabetes Association. They are stable for these are stable for the last 12 years, the same. It was not changed. So the criteria for diagnosis of diabetes: we should have a fasting blood sugar more than 126 milligram per deciliter, which is 7 millimole per liter, or it's 2 hours after doing 75 gram oral GTT with blood sugar more than 200 milligram per deciliter, which is 11.1 millimole per liter, or hemoglobin A1c of 6.5% or more, or a patient who is presenting with the classical symptoms of hyperglycemia, hyperglycemic crisis, with a random blood sugar of more than 200 milligram per deciliter, which is 11.1 millimole. So these are the main criteria which is done by the American Diabetes Association. And if you ask me why they choose just per se 126 milligram for a fasting blood sugar, and this is based on retinopathy data that they found at this number, 5% they get some sort of diabetic retinopathy, since diabetic retinopathy is a duration dependent. And that's why even when they choose the hemoglobin A1c of 6.5 or more, it was based on retinopathy data on 2 population, an Australian population and Egyptian data. So these are the cutoff value for these numbers. It's not an arbitrary thing. It was based on diabetes complication. But the problem, each of these screening tests has a pre-analytic and analytic variability. You could do the fasting blood sugar today, which became abnormal, and you repeat it next day and became normal. So each one, all of these tests, the fasting blood sugar, the 2 hours post 75 gram OGTT and hemoglobin A1c, all of them, they get some pre-analytic variability when they will be repeated. So the statement from the American Diabetes Association that unless there is a clear clinical diagnosis, that's to say that the patient is presenting with symptoms of hyperglycemia, polyuria, polydipsia, and blood sugar more than 200 milligram per deciliter, which is 11 millimole, unless this is present, we require to have 2 abnormal screening tests, either from the same sample or 2 separate tests. And another notice by the ADA, when there is a discordant result. So if a patient has a discordant result from 2 different tests, then the test that is above the diagnostic cut point should be repeated. And we should really be careful about we should consider the possibility of A1C assay interference. So this is really very important notice. So if you have 2 abnormal tests, like our patient, the fasting blood sugar was totally normal, the hemoglobin A1c was abnormal, so the repeated hemoglobin A1c was again abnormal. I think till that point we have only 1 abnormal test, but we have to consider an A1C assay interference. So for our patient, since we were in dilemma, we did for him 75 gram oral GTT and showed a fasting blood sugar 4.7 millimole and 2 hour post oral GTT 5.9. So it was totally normal OGTT. So that patient changed, the diagnosis was changed from type 2 diabetes that became abnormal to have a normal blood sugar. And we have to know that hemoglobin A1c is a surrogate marker for hyperglycemia. So why to use hemoglobin A1c as a tool of diabetes diagnosis? So let us go through the history of hemoglobin A1c. So the first time to isolate hemoglobin A1c was in 1958, and after that, after 11 years from isolation of the hemoglobin A1c, it was found to be elevated in patients with diabetes mellitus. And then they waited till 1976 when it was documented to be a biomarker for monitoring of blood glucose in patients with diabetes. But the new era, these people, they waited for 34 years and until 2010, the American Diabetes Association published revised criteria for diabetes mellitus. They include hemoglobin A1c equal or more than 6.5 as a cutoff value for diagnosis of diabetes, and they stated that A1c cut point of equal or more than 6.5% will identify fewer individuals than the fasting blood sugar cutoff value of 126 or more, but the greater ease with which the A1c test can be performed will enhance the likelihood of identifying more individuals with diabetes. Whether this is true in our population or not, we don't know really, since we don't have data on Saudi population. But they stated that if you use the A1c for diagnosis, you have to use an assay through the National Glycohemoglobin Standardization Program. So it has to be NGSP approved to make just like A1c, which is an accurate and reliable for diagnosis. And A1C correlate with the average blood glucose and correlate with diabetes complications. So it was documented that the A1C is good really for monitoring and correlate with the average blood sugar and correlate with diabetes complication. So what is the advantage of using A1C as compared with fasting blood sugar or oral GTT? As said by Dr. Anas, it has greater convenience. So fasting is not required. The greater pre-analytic stability. So it is the least among the three tests which has variability. So it has less day-to-day variability during stresses, changes in diet or illness. So it is the least to be variable. So you could have more variability with fasting blood sugar or 2-hour post 75 gram oral GTT. We could have also variability even with hemoglobin A1C, but it has less variability than the other two criteria for diagnosis of diabetes. So diagnostic cut point of both glucose and A1C are based on consensus judgment regarding optimal sensitivity and specificity for the complications of hyperglycemia. So this is the hemoglobin electrophoresis. This is the A1C. So hemoglobin consists of a variety of subfraction and derivatives. The A1C is formed by reaction of glucose with the N-terminal amino group of beta chain of normal adult hemoglobin A. What was found with A1C that there is disparity or with the race. So it is also documented in United States that the distribution of hemoglobin A1C concentration in non-diabetic, non-Hispanic white, and non-Hispanic black and Mexican American in the nation by the NHNAS were different in non-Hispanic black have different higher value. So the black people, they are expected to have higher hemoglobin A1C, and this is from 0.1 to 0.3% only. So it's really just a minor difference. So this is the estimate average glucose, and this is data we're taking from a study called International A1C derived average glucose. It was taken from 2,700 glucose measurement over 3 months per A1C measurement in more than 500 adult of type 1, type 2, and non-diabetic patient. So if you want to go through this average estimate of glucose, you can. It is published in the ADA guidelines and in the HbA in NGSP website. So what is the cause of the discordance of hemoglobin A1C? We could have falsely high hemoglobin A1C, like my patient. If you have anything, if the patient is affected with any condition that prolong the red blood cell lifespan, like iron deficiency or iron insufficiency, vitamin B12 deficiency or insufficiency, or folate deficiency. And by the way, my patient has an iron insufficiency. He has a normal blood sugar with falsely high hemoglobin A1C. The condition which cause falsely low hemoglobin A1C, anything that can reduce the red blood cell lifespan, like hemolytic anemia, iron, folate, and vitamin B12 supplement, and patient treated with erythropoietin. So how much the influence of iron deficiency on hemoglobin A1C? I could quote only a very old study in 2002, and it was documented that the iron deficiency anemia can lead to inappropriately rise in hemoglobin A1C of 1 to 1.5%. So, which fall after iron treatment. So the patient who was having hemoglobin A1c of 6.5, maybe his hemoglobin A1c was 5%, and the falsely high was related to iron deficiency, and he was not anemic, so it was mainly iron insufficiency. There are other factors that might affect hemoglobin A1c measurement, which is the hemoglobin variant, and the most common variant, we have hemoglobin S, which is really very common in our population, at least in the east part and the south part. They have like a quiet number of patients with sickle cell, either trait or sickle cell anemia. Hemoglobin E, and hemoglobin C and hemoglobin D, all of these hemoglobinopathy might affect the hemoglobin A1c. So what is the reference? The reference is the NGSP website. It contains a comprehensive information on hemoglobin variant interference. You could reference, you could go to the website and get the interference with each assay and the hemoglobinopathy which is affected by that assay. So what was found that hemoglobin A1c is an excellent marker that correlate with the complication, and this is just when UKBDS, which is the landmark trial, it was started in 1970s, and what was found in UKBDS, which is the landmark trial for type 2 diabetes, that each 1% reduction in hemoglobin A1c, it correlate with 21% reduction of death, 37% reduction in all microvascular complication, 14% reduction in heart attack, 43% reduction in amputation and fatal peripheral artery disease, and 12% reduction of stroke. So hemoglobin A1c is really correlate with the with complication directly. So the lower the hemoglobin A1c, the lower the complications. The same finding was also just found in type 1 diabetes, but mainly in microvascular complication. So we have the DCCT, which is the landmark trial for type 1 diabetes. They found that the lower those who were treated intensively and they have the lower hemoglobin A1c, they were having lower complication of retinopathy and lower microalbuminuria, which is the main biomarker of diabetic nephropathy. There are, of course, other biomarkers that estimate glycemic control, like fructosamine, glycated albumin, and 1,5-anhydroglycitol. All of these biomarkers are less popular than the hemoglobin A1c. On regard the glucose monitoring devices, we have the self-monitoring blood glucose devices, which are the GlucoCheck. These devices use the finger prick or finger stick to check the blood glucose, and it was demonstrated in many studies a positive relationship between the frequency of SMBG and improvement in hemoglobin A1c in people with type 1 and those with type 2 who are using insulin. The other thing which is used for monitoring blood sugar is the continuous glucose monitoring. In the Saudi market here, we have two main type of CGM: the intermittently scanned flash or CGM, which is the Freestyle Libre, and the real-time CGM. And we have different types of real-time CGM. So this is the main differences between these. So like the flash time or the intermittently scanned CGM, it can be used for 14 days, while the real-time CGM, it's used between 7 to 14 days. there is no calibration needed for the flash or the freestyle library, and some of the real-time need calibration, other they don't need. And we use the real-time CGM to be augmented with insulin pump to have like a closed loop insulin pump. So since we have the standard, we have the CGM, also just the American Diabetes Association, just they make a standard for the CGM as part of the clinical care. So each CGM device is recommended to be worn for 14 days, and the percentage of time CGM is active recommended 70%. So they recommend a glycemic variability or percentage of coefficient to variant target less than 36%, time in range, and time in range, time above range, and time below the range. And these are the recommended profile for time in range in CGM or freestyle library or the intermittently scanned flash. So we should have the target time in range more than 70%, and the one below range less than 4%. For the severe or level 2, time below the range should be less than 1%, and the time above range should be below 25%. So by that one, we set a glycemic target, but for a glycemic target, we set it by hemoglobin A1c. Each individuals should have different glycemic target based on the comorbidity, disease duration, risk of hypoglycemia, established vascular complication or not, and the resources and support system. So you could use stringent hemoglobin A1c less than 7% for somebody who's young, type 1, and the life expectancy is really high for him or long for him, with the duration of diabetes which is shorter. But if you have a patient who is old with ischemic heart disease or stroke, you could reduce your hemoglobin A1c target to less stringent, to be like 8% or 8.5 to avoid the risk of hypoglycemia. So these are the glycemic target. The general glycemic target for non-pregnant hemoglobin A1c is 7%, but it should be individualized for each person. For the CGM, we should have time in range more than 70%, time below range less than 4%, and time above range less than 25%. So the take-home message from this presentation that diabetes mellitus is a common disease and has financial and personal implications. So it's really very important to establish diagnosis rightly. So whenever you diagnose the patient as diabetes, the insurance will have different price. So the diagnosis is really crucial. In individuals with asymptomatic hyperglycemia, be careful about discordant result, especially with hemoglobin A1c. Hemoglobin A1c is a reliable, good tool to screen and monitor glycemic control in individuals with diabetes mellitus. And after setting glycemic target, choose the appropriate tool of monitoring to achieve good glycemic control. And by this slide, I end my talk, and thank you very much for listening.
Thank you, Dr. Abdelghani, for this very useful information, and thank you for your time. Before going to the second topic, just let me to mention here that this webinar has 2 CME. Once finished this webinar, you will receive in your email a survey from the society. After answering this survey, within 5 days, you will receive the 2 CME hours. So this is for your information for all the audience. I am seeing that a lot of questions regarding this matter. Okay, now we will start with Mr. Ayman Al-Haik. Mr. Ayman Al-Haik is a senior diabetes educator in Prince Sultan Military Medical City. The topic is very important also. It's a hemoglobin A1c assessment of a different derived methods relative to the central lab method. So please listen to this very important slides from Mr. Ayman Haig. Please, Mr. Ayman, go ahead.
Bismillah, assalamu alaikum. Slides are clear, Anas?
Yes,
Yeah.
I can see.
Okay. Assalamu alaikum and hello everyone. Thank you all for joining our today webinar, and thank you for Saudi Society for Clinical Chemistry and for SPOCTA for arrangement for this very important webinar on the advances in hemoglobin A1c measurement techniques. Actually, my presentation agenda for today is going to be to share with you a local experience data as a real-world data and evidences coming from the Kingdom of Saudi Arabia. And these series of publications that have been done in the last 2 years on the utilization of different techniques on HbA1c testing, including the POCT standard lab, the estimated A1c by the glucometers, as well as the estimated A1c or the glucose monitoring indicator as derived by the continuous glucose monitoring devices used by diabetic patients. As all of you know that diabetes is looming disaster globally, and in particular in Middle East and North Africa region, and more specifically in Saudi Arabia, diabetes is considered as a major health challenge in Saudi Arabia, impacting the health care system, with more than 7 million patients were diagnosed with diabetes and 3 million with the pre-diabetes stage. So we reach as an straight to alarming era of this major health challenge in our population. And as per the WHO and the IDF, they have ranked Saudi Arabia as having the second highest rate of diabetes prevalence in the Middle East and North Africa, and the seventh highest prevalence of diabetes globally. And since 1968, as Dr. Saeed said, the gold standard for diagnosis, for initiation the medication, and the shifting and changing the regimen of treatment for patients with diabetes were all done based on the gold standard for diagnosis and for initiation the medication for patients with diabetes, based on the standard laboratory A1c as done in the lab. And as per the major association and consensus for the American Diabetes Association, Canadian, and the ACE, they requested the HbA1c to be done at least 3 to 4 times annually for patients who have stable glycemic control. However, the ADA, the Canadian Diabetes Association, and the ACE, they requested to be done more frequently, 5 to 6 times, if the glycemic control is unstable or non-satisfactory, and for any patients who are or she undergoing changes in their treatment regimen. And since everything is based on the glycemic control for patients with diabetes, so the level of glycemic control is very important to be understood by the patients as well as by the healthcare professional on the frequency for testing for the HbA1c. And according to this major published data from the Kingdom of Saudi Arabia, which included more than 17,000 patients, unfortunately is showing that the majority of our patients based on the HbA1c done in the laboratory, that the majority of our patients, whether they are from type 1 or type 2 diabetes, they have a poor glycemic control with more than or equal 7% for HbA1c. And these results also has been confirmed by the local data from the major tertiary hospitals who are dealing with the patients with diabetes. It's also showed the patients with type 1 and type 2 diabetes, they have a very poor glycemic control based on the HbA1c test. Again, going back to the compliance and adherence from the patients on the adherence to the requested HbA1c testing, and upon reviewing the literature, that you will find only one study that has been conducted in Saudi Arabia on the level of adherence and compliance for HbA1c testing as requested by the healthcare professional to the patients with diabetes. And this study, unfortunately, it showed that we have a very low adherence rate to the HbA1c, in particular for primary healthcare centers. And this standard, mean standard for HbA1c testing were 1.3 times compared to the benchmark standards, which is 3.8 times in a year for patients with a good control for their glycemic control. And despite we as healthcare professionals, including physicians, diabetic educators, lab technicians, nurses, health educators, we used to advise and to instruct and to tell our patients that it is very important to increase your awareness about the adherence and the compliance for the testing frequency for the HbA1c. However, there is a major challenges that impacted our patients to do the traditional or the laboratory HbA1c testing as been advised by the healthcare professionals. And these the major reported, reasons from the patients, including the inconvenience associated with the revisits to the hospital and another additional visits were required to the lab. Sometimes the test cost is one of the major limitations to do the HbA1c testing. And the awareness level on the importance of the frequent testing for the HbA1c, but in particular for patients with type 1 diabetes, those who have the needle phobia. So they are not preferring to do the phlebotomy in the laboratory to do the HbA1c test. Some patients, they have difficulties in handling the absence from the school or from their work to have an additional visits to the hospital to do the additional visit to do the HbA1c test and additional visit to be discussed with their physician or to the health educator if there is any indication to do any adjustment for their medication. And with the changes and the revolution that happened recently, to overcome all of these patient-reported challenges to do the HbA1c into the laboratory as a standard, there is different techniques and methods that support the patient to reduce the turnaround time, to improve their satisfaction, to improve their glycemic control, also to improve their discussion and engagement in their health status. These devices introduced recently into the market, including the point-of-care testing devices, the home use kit for HbA1c testing, the estimated A1c by the, as Dr. Saidi said, by the conventional blood glucose testing devices or the glucometers, as well as the estimated A1c or the glucose monitoring indicator as being derived by the continuous glucose monitoring devices. So all of these devices, it's shown in the literature that it reduced the turnaround time, it's improved the patient satisfaction, improved the patient adherence and compliance to the required or to the requested testing frequency from their healthcare provider. And finally, it reduced the cost for treatment of the diabetes-related complication, whether it's an acute or long-term complication due to the poor glycemic control. And since 2005, with the first POCT have been launched into the market and been used widely in the Western experience hospitals, the HbA1c testing, it showed and it's been approved in the many literature that it improved the adherence for recommendation for HbA1c testing. And the frequency was associated with better glycemic control and reduced the indirect and direct cost for the management of diabetes-related complication. However, no studies have been conducted from our region, including Saudi Arabia, on the value of point-of-care testing for HbA1c, and especially in the major tertiary hospitals in Kingdom of Saudi Arabia. So we decided to have a local experience study as a real-world data on the proper utilization for the HbA1c testing as a near-patient testing using the point-of-care testing devices in our institution, Prince Sultan Medical City, and our evidence-based for this local experience study was based on the published data that the rapid availability of point-of-care testing in all clinical areas have been shown to facilitate diabetes management, improve the patient satisfaction, and improve the glycemic control, and reduce the direct and indirect cost for the management of diabetes and its related complication. And we succeeded to publish the results for this local experience study from the Kingdom of Saudi Arabia. Unfortunately, this study have been acknowledged by the journal that it considered the first study in the Middle East and North Africa region explored the patient satisfaction and the glycemic control improvement following a rapid implementation for point-of-care service for glycemic control measurements. In our study, that in addition to the other primary and secondary endpoints for the local experience study, that we have identified what are the most common reasons compared to the other experiences. Why do our patients, they are not adherents or not compliant to the traditional HbA1c into the laboratory? That we have the majority of our studied sample that reported that the revisits involve other inconveniences, additional costs or co-payments due to the travel for having additional visits to the hospital, another visit to the lab, and the time taken to be discussed with the healthcare professional, difficulties in absence from school or from work, and even we have 8% of our patients, they have a poor awareness on the importance for testing frequency for the HbA1c as been advised by their healthcare professionals. We have developed and distributed a patient satisfaction survey on the implementation for the point-of-care testing within the studied sample. And fortunately that we have a significant improvement in their responses to this questionnaire, which have been developed into Arabic and distributed for all the patients use this service. And these subdomains, they have shown that a significant improvement in their satisfaction level after implementation the point-of-care testing devices as a standard of care for their glycemic follow-up. So as example, but not limited to, and for the collection process, confidence in the process and the confidence in the results. So they were confident about the results derived by the point of care compared to the A1C. They were also convenient on the not having a travel to outside would be convenient for them to have an additional visit to the hospital. Also the disease management and their engagement and their discussion and communication with their healthcare provider, it's been improved since the rapid availability of the HbA1c results were available upon their visit to the healthcare professional. So it's will strengthen their relationship with their physician and with their healthcare providers. Again, with these advancements in the diabetes technologies that seeking for better glycemic control and to improve their satisfaction and to reduce the turnaround time that can be happening due to the additional visits to the lab to do the HbA1c test. And with, as Dr. Saeed said, with the huge revolution that recently happened in the Kingdom of Saudi Arabia, with more than 200,000 users for the CGM, BGM, continuously by major institutions in Saudi Arabia, and in particular for the CGM, whether this real-time or intermittent continuous glucose monitoring devices, that these devices, unfortunately, it's giving something which we call it estimated A1C for the devices that's being used by the patients on daily basis for self-monitoring of their blood glucose levels using the conventional blood glucose devices. Also, the average or the estimated A1C, previously known as estimated A1C, and the current name is the glucose monitoring indicator, which is the average of the readings for the continuous glucose monitoring readings, which is most of the devices that it will measure every 5 minutes the blood glucose level, the interstitial glucose levels for the patient, and this data will be saved on the cloud, and this will generate, if the patient is using, as Dr. Saeed said, for more than 70% of the sensor captured data for 14 days, it will give them something which we call it the glucose monitoring indicator. It reflects the estimated A1C, as well as it will, some studies it's shown that it's comparable with the POCT or the standard laboratory HbA1c. However, there is a huge debate on the GMI estimated A1C, POCT HbA1c or the home kit A1C compared to the standard laboratory HbA1c testing for A1C results. And upon reviewing 128 publication published in the PubMed that you can find there is a marked discordance between the laboratory and the estimated, whether the patient they are using the continuous glucose monitoring devices to generate the indicator, which is the glucose monitoring indicator. Also, the estimated A1C as generated by the conventional BGM devices. And if there is a confirmed discordance or limited agreement between the A1C as done into the lab, as it is the standard of care, compared to the generated GMI or the estimated A1C or to the BOCT, this definitely it will lead to the errors and it will affect the patient safety because it will affect the diabetes management in terms of titration taken and clinical decision based on the results generated by any of these available methods. And because of this debate, and because we do believe that the research will provide more evidences based on our local experience study from Saudi Arabia, and since we don't have any publication in terms of the level of agreement or discordance between these methods as GMI, estimated A1C, BOCT A1C, or to the lab, or even to the home kit A1C, so we decided to do our local experience from Saudi Arabia, and luckily we published the results for this, for this local experience study in the Diabetes Therapy Journal in 2022, and the focus of this study where it was also labeled as the first study in the Middle East and North Africa to assess the level of agreement and correlation between the different A1C as generated by the BOCT home kit, estimated A1C by the conventional or the standard blood glucose monitoring device, as well as the glucose monitoring indicator generated by a continuous glucose monitoring metrics, compared all of these results or GMI, the estimated A1C, were compared to the standard laboratory A1C as done as same day visit for any patients. All of you know, and as been explained by Dr. Saeed, that the estimated A1C or the glucose monitoring indicator, it will convert the CGM readings if the patients they are using more than 14 days for more than 70% sensor capture data for at least 14 days. And as I mentioned earlier, there is no any real-world data from our area assess the level of agreement between these different methods for generation for the GMI estimated A1C compared to the standard laboratory. And we have done this study in our major institution, tertiary hospital, that we have compared the sensor capture data to generate the GMI metrics. Also, we have compared these with the point of care testing, and so compared to the all of these parameters have been compared to the same day visit lab HbA1c as a standard for comparison group. So the rationale for this study is to compare all of these GMI by continuous glucose monitoring, estimated A1C as average estimated A1C derived by the conventional self-monitoring blood glucose devices. We compare it to the point of care testing as well as with the laboratory HbA1c. And just a notice here, it was the same day visit to avoid any confounders that could happen in our study analysis. Okay, and we have followed a cross-sectional study design for our study, which have been as center-based single-arm ambisective study design, and it was as a part of our local experience and quality improvement project to assess any potential discrepancies or discordance between the laboratory to the other estimated A1C generated by the continuous or by the patient used glucometer devices. We have included all the variety from type 1 type 2 diabetic patients. Also, we have included any patients with the sensor capture data with more than 70 time users. For any patients, those who are using the conventional or the standard BGM, they have to test at least twice in a day. However, we excluded any pregnant lady, for any patients who have a diagnosis of diabetic ketoacidosis, or the patients who are non-frequent users for the continuous glucose monitoring with less than 70% of the sensor capture data. The other primary goals in our study is to assess the correlation between the level of correlation between the point of care device generated HbA1c compared to the standard or laboratory, as well as if there is any correlation between the point of care testing with the estimated or the glucose monitoring indicator metric. We have collected all the socio-demographic data, treatment modalities, diabetes duration, and for all the patients, we used a specific platforms that are provided by the manufacturer for the self-blood glucose monitoring devices that we have downloaded using a special platform for the 30 days and 90 days readings, as well as we have downloaded using a special platform for the patient, those who are using the CGM. Also, we have asked the patient to do a same-day test for their HbA1c, and all of these data to avoid any human intervention have been saved using a special platform for analysis and for study for any correlation for these 28, 90 days, and 14 days, as well as for the HbA1c testing were derived from the electronic medical records for the particular patients. So we have, as a result for our local experience study, that's our study have included both genders from males and females and represented all the diabetes treatment modalities used for our patients, whether they are insulin users or combination, or even from the patients who are using the insulin pump therapy. And if you can see here that we have included also other parameters and metrics, which is we can use it in additional studies in the future. So based on the level of agreement analysis between the point of care testing compared to the laboratory or to the standard HbA1c, also by the estimated or conventional SMPG devices, that we have found a comparable mean between the HbA1c as derived by the HbA1c, whether it's done into the lab, compared to the HbA1c done by BOCT. And also this results remain significant after implementation of the further analysis for this derived metric by the BOCT compared to the laboratory one. Also, when we compare the BOCT results for HbA1c with the GMI as from the freestyle Libre users or the continuous glucose monitoring devices, also there is a significant correlation between the BOCT HbA1c compared to the lab to the GMI derived by the CGM for the both periods, for the 28 periods and for its remains also for the 90 days period of using for the CGM. For the mean BOCT HbA1c value for the patients who are using the conventional BGM devices based on the finger prick, it's also there is a significant correlation between and level of agreement. It was high using the Bland-Altman analysis. It was remaining significant for the 90 days as estimated A1C compared to the lab, also for the baseline 30 days for the BGM estimated A1C compared to the lab one. These correlations also, it was, remaining for the R value and the explanatory for other value for the other factors, including the treatment modality, including the age and the diabetes related related complication, as well as for the diabetes duration. This correlation, it was significant and positive after implementation of the analysis for all of these factors. That's this one. It's reflected also for the continuous glucose monitoring and for the BGM users compared to the laboratory one. Overall, the mean laboratory HbA1c and the point of care testing HbA1c for both group, whether they are using the continuous glucose monitoring or for those who are using the conventional blood glucose monitoring systems, were also almost comparable with no significant change. So the mean average for the HbA1c for both groups were comparable based on the A1c and the BOCT, with a significant correlation and a good level of agreement between the HbA1c as done into the laboratory compared to the BOCT as a same day test if done using the BOCT measurement devices. So based on our study that we have concluded that there is a high level of agreement between the GMI, whether the patient they are using the continuous glucose monitoring or the standard blood glucose meters, and because of the high advantages of the continuous glucose monitoring, and because it became very popular in our region and particularly in Saudi Arabia, and this is became one of the standards in the center of excellences to rely on the GMI. So we recommended our patients to have whether the laboratory or the POCT or the estimated A1C by their continuous glucose monitoring, or the by the average if they are using continuously the blood glucose monitoring devices as a finger prick standard. However, if the patients we need a rapid test for HbA1c, it's recommended to have it if the patient have a same visit with his or her physician, to have a POCT devices or to download the GMI by the devices that the patient using. However, we still recommend using the for the initial diagnosis for diabetes and for the safety for the patient, still the standard laboratory method is still recommended even by the major associations. And just because that we did not stop based on these two studies and based on the published literature that we have concluded that the traditional approach for employing, as Dr. Saeed said, that the A1C is one size fits all screening tool for diabetes. Has been challenged recently by the concept that being declared by the time range consensus and by the American Association for Clinical Endocrinologists and by the ATTD consensus, because the concept of the time and range and the glucose variability, it's still recently a debate exists about the independent impact of glycemic variability and the time and range, and how much the patient is spending that within the range of more than 70%, or how is the fluctuation ups and down, the hyper and the hypoglycemia. This is the major, factors controlling the long-term complication associated with diabetes rather than the HbA1c. Because of the prolonged recurrence of the episodes of the hypo or hyperglycemia, and it is very important, and it will control our therapeutic standpoints in our patients with diabetes. And it is very important to reduce the glucose variability and to improve the time and range with our patients, those who are, using the continuous glucose monitoring devices or the continuous user for their BG devices. However, the clinical use of the time and range for patients with type 1 diabetes and the insulin users from the type 2 therapy has not improved despite it's shown its effectiveness and its importance to control the cost related to the management of the long-term complication, also to save the life for our patients. However, based on that, it's not intensively discussed and investigated in the published data, not only from our region, but even from the Western experience. So based on that, the current, we decided to do our next study to compare the point of care and laboratory glycated hemoglobin A1C and its relationship with the time and range and the glucose variability. And what we have done here as a local experience study, we have included all the patients from all the treatment modalities, from all the diagnosis of diabetes, whether they are type 1 or type 2, and we have asked them to do the POCT converted to the lab. And the main aim and the primary aim is to have insight on if there is an association between the HbA1c as a correlation, whether it's from the lab or the point of care, compared to the time and range and the glucose variability. And we have found that based on this study, there is a significant correlation, statistically significant and clinical significant correlation between the A1C as measured into the lab compared to the point of care testing. Also, the significant correlation and the clinical significant correlation, it was significant as association within the time and range and the glucose variability. So Based on this, and because it became most widely used within our population and our patients in general, they are adherent to the blood glucose monitoring based on the finger pricking and with the huge penetration for the continuous glucose monitoring, and it became widely used for the point of care, that we should rely on the time in range. Glucose variability should be used also as endpoints, not only based on the HbA1c as a standalone, judge for the glycemic control as a valuable parameter also in the diabetes therapy for our patients with diabetes. So we should take all in consideration that the glucose variability, time in range should be used also as endpoints and valuable parameter for the therapy of the diabetes patients. Here I have done my presentation, and thank you all.
Thanks, Ayman, for this excellent and wide details of presentation. Okay, let me just to apologize about Dr. Assalam. Dr. Assalam, she would not attend this webinar due to the personal issues. Now the mic or the topic about hemoglobin A1c, the what, the why, the how. It will be presented by Ms. Amjad Al-Ataibi. Amjad Al-Ataibi, she's a medical technologist working in a point of care clinics at King Faisal Specialty Hospital and Research Center in Riyadh. So please, Amjad, go ahead. Let me just to start from my side.
Assalamu alaikum.
Alaikum assalam.
Assalamu alaikum. First of all, I want to thank the Saudi Society for Clinical Chemistry and the team here to give me this opportunity to be part of this webinar talking about very important test in our lab, which is hemoglobin A1c. So I'm glad to talk about this very important topics. We will start by what is the hemoglobin A1c, then why we have to perform this test in our lab. Then we will talk about the how we can validate new instruments or assay. By end of this presentation, we will cover the definition of the hemoglobin A1c and the protocol in our lab, and we will distinguish between the common method that we use in our laboratory, and we'll explain how we can initially validate any new instrument or assay. When we said hemoglobin A1c, we mean the specific hemoglobin, which is glycated hemoglobin when the sugar sticks in our red blood cell, and that's happened when the N-terminal villi residue of the beta chain of hemoglobin A being modified, and the sugar will be accumulate in our red blood cell. And this component, it's very essential to diagnosis the patient, as Dr. Said and Mr. Ayman said, diagnosis the patient with diabetic and for management the patient with this disease. Also, this reflects the concentration of the blood during the previous 8 to 12 weeks. Hemoglobin A1c, it's also related with the risk of diabetic complication as the team explained there, and also it's gold standard for diabetic patients. Now we will talk about the very important part for any lab having this test, which is the test methodology, and we will talk in this session about the hemoglobin A1c common method used in our lab. First method we'll talk about, we call it the molecular charge, which is example of HbA1c and electrophoresis. The principle for this method is to separate the glycated from non-glycated hemoglobin, and this is happened by the difference of charge. Usually the glycated hemoglobin carries the negative charge, and this system usually it's a fully automated system, and the analysis time it's less than 5 minutes. The CV for this method is started from 1.6 till 2.7, and it can be detect more than one variation in the patient hemoglobin. For example, hemoglobin S, hemoglobin F. The disadvantage for this method is it's a cost effect and it's costly high. So the implementation in the laboratory can be demanding, and also it's considered as a complex as CAP. It's a complex method which is need operator with skill enough. He can differentiate between the different methods and or different variation in the same hemoglobin, and also it's depend on the temperature and the environment of the instrument. The second method, we call it molecular structure method. For example, the immunoassays, the molecular structure method principle is to determine the structural of the variation. So it's about the antibiotics, which is target the N-terminal glycated immunoassay beta chain. This is commercially available, and the CV between 1.6 to 6.1, and also it's easy to operate and it can be added for any existing machine. The disadvantage for this method is all about the interference. And where the antibody can target the variation, so such as hemoglobin S and hemoglobin C can cause false increase of hemoglobin A1c. And also some patients, they have a mutation on the few amino acid chain of the first few amino acid chain of the beta chain. The second molecular structure method that we have in our laboratory, we call it, for example, pronate affinity chromatography, and this is also structure variation. The principle for this method is when the aminophenyl boronic acid react to the glucose, which is in the red blood cell. This is commercially available, and not affected by the temperature, and the CV between 2.1 and until 3.1. This is also less interference with common variation. For example, hemoglobin S, F, and C. The advantage for this method is when some patient with thalassemia have it's thalassemia cases when the patient have 10 to 15% of hemoglobin F, it will be interfere with the result for hemoglobin A1c. And also it's need more than one equipment. It needs sometimes computer to detect and record the result. So it needs more technical stuff because it needs more equipment. Now we will talk about very important part of the testing hemoglobin A1c in the lab or in the main lab. We call it the hemoglobin A1c limitation. Any test in the lab has a specific limitation, and for the hemoglobin A1c, the lifespan for red blood cell, it's the main limitation for the test. Some patient with the lifespan for RBC's lifespan less than the normal, which is the average 120 days, it's give less or falsely less hemoglobin A1c result. When the patient have also RBC lifespan more than the normal, which is 120 days, it will give more hemoglobin A1c results. And also the population of the variation, the patient population and the variation in the patient blood, for example, hemoglobin S and hemoglobin A, and increasing of hemoglobin F, which is affect the result of hemoglobin A1c. Also, in some patients with renal failure, they have the hemoglobin, we call it carbamylated hemoglobin, which is the patient taking some treatment which can modify the hemoglobin. Now we'll talk about the third part in this presentation, which is very important for any instrument in the lab. We call it the validation or verification. And the standard validation process for hemoglobin A1c instrument we will start by precision protocol, then we'll do the accuracy or correlation, which is compare the old or all to new, or we will compare the known value samples with the new instrument. We will do also the linearity and carryover. Also, it can be by the manufacturer. And we'll talk about the software and connectivity for the hemoglobin A1c devices. And also we'll talk about the specimen stability and the time study. The precision study, when we say the precision study, we are talking about the replication of the run from the same sample to evaluate the random error. It should be 20 reading for 2 levels of quality control for 5 days, and the run will be within the days and during all the 5 days. The run also, as I mentioned, it will be within the day and during the 5 days. Then we will calculate the coefficient of variation. The coefficient of variation should be less than or equal the manufacturer specification, and also should be less than the total allowable error, which is provided by our standard client. The total allowable error for A1c is 6%. Here, example of template for precision study done for the hemoglobin A1c instrument. We can see here the analyte, it's hemoglobin A1c. The manufacturer precision was 2.1, and our standard should be for 33 from CLIA with 1.89, and this is for the run between the day. We can see the obtained result or the observed result for the normal control. CB was 1.5, which is acceptable, and for abnormal control, which is 2, the result were 2, also which is acceptable because it's within the total allowable error and the manufacturer less than or equal the manufacturer precision. The next paragraph, the next table, for the run within the day. This is example of the result obtained. The manufacturer were 1.6, and the standard should be 25% of CLIA, which is 1.5. The results, the observed result, 1, and for the abnormal and for the normal, and for the abnormal it was 1.5. When we compare the result, it was acceptable. The second protocol in the validation standard is, we call it the accuracy or correlation. We in the accuracy we run the true value of substance being measured. For example, BT sample, we run known concentration from the old machine to the new machine, and the sample should be 20 sample, not less than 20 sample as per the standard, and the test in duplicate. So the normal and should be covered, the AMR should be covered during the accuracy study, and should be included normal and abnormal population. It will be compared reference instrument to the known values. We can use the patient sample or quality control, as I mentioned, or proficiency sample. The correlation coefficient should be more than 0.975. Also, there is acceptability criteria. We call it error index. We will calculate the error index, and should be from 1 to -1, and the percentage of the index should be 95 and above. So the error index should be within 5%. Here example accuracy and correlation data for hemoglobin A1c instrument. We can see the analyzed hemoglobin A1c, and the total allowable error is 6% as per CLIA, and the correlation of coefficient R, it's should be greater than 0.975, and we get 0.997, which is acceptable, and the percentage of the error index was 95, which is acceptable. Now we'll talk about third protocol in the validation. We call it the linearity. In the linearity, we are testing the relationship between the measured, analyzed, and known concentration of any analytes, and for any state range. The minimum sample that use the minimum number for linearity sample, it's 5 sample, and it's run in duplicate and equal, which is the result, which is equal the distance from each other. So the linearity material can be quality control, calibration, or commercial linearity. And we get the result and we plot it immediately to identify the outliers and correct the correct and outliers. The acceptability criteria for the linearity, the method, we can consider the method is linear method if the values is less than the allowable error for each specimen point, and the systematic error must be less than 50% of the total error. Here we have linearity template for the hemoglobin A1c. We can see the allowable systematic error, which is equal 3 because of 50% of total error allowable, and the result was linear as the data. And we'll talk now about the third or fourth protocol for validate any instrument. We call it the analytical measuring range, which is what is the analytical measuring range, or AMR, the range of analyte that the method can directly measure the specimen without any dilution. When we said how we can differentiate between the AMR and the clinical reportable range, CRR, the CRR is the range of analyte value that method can report as a quantitative result, allowing the dilution or the concentration or any sample that can use to extend the AMR. So why would the lab have to perform the CRR to cover the grade 4 toxicity table? So the AMR, we can consider the AMR as acceptable if the reportable range must be within the manufacturer range. We can see the template here. We can see the manufacturer range for hemoglobin A1c started from 2 to 10, and the reportable range also 10 to 10. So after the dilution was 1 to 5 dilution, that we get the CRR, which is 2 to 50%. Now we'll talk about the carryover study. The carryover study, why we have to do the carryover study for any instrument, used to ensure that no carryover from high sample to next. How we can do the process, we will run known high patient sample followed by known low patient samples to see the result of the low level if it's affected or not by carryover. If the carryover is detected, the laboratory must determine the analyte concentration above and should be consider this value in the procedure. There is a great guideline for how to perform the carryover, which is under the SMILE validation resources. I included already in the reference. Now we will talk about the last protocol we have to perform it for any instrument or assay. We call it the reference range or reference interval. We will set the reference interval when we test the normal range for the normal range interval. So we will choose 20 patient healthy non-diseased, and we will run the test for them. Then we will calculate the acceptability criteria. The acceptability criteria should be for 20 patient normal patient, 90% from them and above should be within the normal range. What will happen if the percentage less than 90%? We have to add 20 patients again. Then if it's outside, we have to establish our normal range in the population. We have to run 120 sample to get our reference range established. This is the reference range for hemoglobin A1c. It's less than 5.7, and this is according to the National Glycohemoglobin Standardization Program, and it was already verified by 100%. And the expectation was, as I mentioned, it's 90% and above. The normal range for hemoglobin A1c, if the patient has below 5.7, we can consider it as a normal, and from 5.7 to 60.4, it can be pre-diabetic stay in the pre-diabetic stage, and if 6.5 or higher, it's indicated as a diabetic patient. Most of our instrument has a tool to be connected to the LSI. So I saw most of them in the market now. Most of them has this tool to be connected directly to LSI. LSI is which is transfer the result directly from the machine to the patient chart, and it can be classified under the auto verification, which is prevent any human error of entering the patient result. Meanwhile, there is some machine lack for this tool in the market. In this case, or in case if the interface was down, the result will enter manually. But according to our standard, any result for the patient entered manually should be done by operator and also checked by the secondary operator. For example, one operator has to perform the result and the second has to verify the result just to check it because it's entered manually. Now we'll talk about the specimen stability for hemoglobin A1c. For hemoglobin A1c, I saw most of the methods that we have in our laboratory. Most of them recommend the specimen should be kept in the refrigerator from 1 week to 2 weeks, and to be stable for the testing and during this 2 weeks. If it's stored under the good temperature from 2 to 80 degrees, and also it should be collected with anticoagulant EDTA, we call it EDTA, and should be run as a whole blood. Thank you, that's all.
Thank you, Ms. Hamjad, for this excellent presentation. I like the third part for validation protocol, actually, for the point-of-care instruments. Now, let us now to move to the last stage in our webinar. We have here some questions. I had got some of them. We will start by first question to Dr. Abdul Ghani. One of the audience asked about using the HbA1c, why will be accurate and reliable in cases like people suffering from anemia. So is it the HbA1c will be accurate for this type of patients?
I think it was widely explained that there are anything which affect the lifespan of the RBCs, it might result in discordance hemoglobin A1c. So if anemia is related to hemolytic anemia, this will reduce the lifespan of red blood cell and will result in falsely low hemoglobin A1c. And anything which might also just increase the lifespan of red blood cell, like iron deficiency or vitamin B12 deficiency, will cause falsely high hemoglobin A1c. So in anemia, I think you have to be sure about what type of anemia. In certain type of anemia, it might affect either falsely high or falsely low hemoglobin A1c.
Thank you, Doctor. Okay, the second question now to Mr. Ayman. This is it's not a clear question, but let me to raise this question. That's one patient got a result within 1 hour from one hospital, and in the second hospital, he or she got the result after 3 days. It seems, Ayman, that's the first result from point of care instrument and the other results within 3 days from the lab. So which one will be accurate? This is I think, yeah. That's the question. So can you answer this one? Ayman, sorry, you are mute. You are on mute.
Yeah, sorry. I mean that maybe Amjad can answer the proper way this that because 3 days to get the results. I think they have done it in the the first few hours, but maybe to be transferred to the system depends on the health information system they are using in the IT format to be reflected on their electronic medical records or the records that the patient that he had. But however, I don't think that 3 days that is taken to do this test, maybe the results to be appear for these patients. But based on our local experience, the first the first one that have been based on the POCT, based on our local experience data and based on the huge number of publications, that it showed a significant correlation and our level of discordance and high level of agreement between the POCT generated HbA1c compared to the lab one.
Okay,
so both results he or she can rely on.
Okay. Another
I
question.
can add a point in this question. The pre-analytical element or factor, it will affect highly affected the result. That's been in the first sample. It's collected in not proper way. It will give a false negative or positive. The second sample, it can be also collected in not proper way, and the third sample, maybe it's the accurate. So we can consider the pre-analytical error, especially with the point of care testing, because it's done by non-lab person, and especially also for home use devices.
Okay, thank you, Ms. Amjad. Third question to Dr. Abdul Ghani. What does the pregnancy affect measurement of HbA1c? Pregnant women's. Is it affected by the HbA1c? You are mute, Doctor.
Okay. Thank you very much for the question. I think there are several factors which affect the pregnancy. You can rely on it during the first trimester or the first antenatal visit before the appearance of the pregnancy. On the it's going to affect the hemoglobin A1c measurement to check for those who have high risk. And even for the cutoff value for hemoglobin A1c, it's still controversial. If it's a clear more than 6.5, the patient will be considered having diabetes. But just you have to bear in mind that the hospital has to use the NGSP methodology. For those with hemoglobin A1c from 5.8 to 6.4, if it's from 5.8 till below 6, still controversial among all the society. For those with hemoglobin A1c between 6 to 6.4, these patients are at high risk of getting pre-diabetes and correlate with the oral GTT, with 75 gram OGTT for gestational diabetes. So you should consider these patients as having gestational diabetes from the start of pregnancy. And they should be treated accordingly. We could use hemoglobin A1c for monitoring for those with a pre-gestational diabetes during the pregnancy in each trimester, just to see the result and to see just that the blood sugar is well controlled. So the recommended hemoglobin A1c during the pregnancy target should be 6.5 or below.
Thank you, Doctor.
Thank you.
Question to Ms. Amjad about you had mentioned in your presentation about the patients who are suffering from the renal failure. So, shall this type of patient didn't do the HbA1c testing at all and depends on the glucose testing?
The issue with those medication affected, or this is, let's say, it's hemoglobin modified. It cannot be especially during the time of the treatment. They cannot rely, the doctor or the physician can rely out of this result because of this variation, and he can consider that the result is not accurate. And I think they have to shift to another method for this.
Okay. Last question to Mr. Ayman. From your experience of using the point of care HbA1c instruments in your clinic, have you touched there is a recovery of the of or not he she or he mentioned about recovery, but let me to re-ask this question. Have you is there any enhancement in the health of the diabetic patients who's controlling the HbA1c by using the point of care instrument in your clinic? I think he or she meant that one patient, he had visit the point of care clinic, and your staff did the measure to him or to her. After that, have you touched that there is a good result of the
Actually, this is also, it was one of the findings of our study, that's having a rapid value or test or results for the HbA1c testing once required by the healthcare professional. It's required on the same day visit with the doctor. It will facilitate the intervention for if there is any requirement for those adjustment for the medication. Also, it will improve, the patient to healthcare provider communication and discussion and the engagement based on the patient-centered care approach. So having the rapid results for using the POCT within the same day visit with the doctor, it will facilitate the engagement and the adjustment required for the medication by the physician. This is definitely, it will be reflected on their glycemic control rather than to wait for several days to get another appointment with the physician once he or she got the HbA1c test, if it's done in the lab. Additional visits or revisits to the hospital laboratory to do the HbA1c testing is considered one of the major possible challenges that might impact the patient's visits or compliance and adherence with the HbA1c testing, which can reduce the adherence and the compliance from the patients. This is also can be definitely reflected on their glycemic control status.
Okay, thank you, Mr. Ayman. I have last question to Dr. Abdelghani about can the patient depend on the HbA1c testing only every 3 months, and didn't you use the home use glucometers for daily measurements, and depends on only this HbA1c result for medication and for lifestyle later on? Mute, Doctor. You are mute, Doctor.
Is it okay now?
Yeah.
Okay.
Yeah, it's okay.
So I think this is an important question. What was found, that for those who are type 2 diabetes who are not using insulin, they are on oral agent, or like type 2 diabetes on diet, they could depend on hemoglobin A1c every 3 months to say their to check their glycemic target. For those who are on insulin, they need to use the SMBG. The purpose for using SMBG is not for checking the blood sugar and not reacting to it. So just I think it's important to use the SMBG and react for it. Like once there is hypoglycemia, reduce the insulin doses, or once there is hyperglycemia, reacting by just having like bolus, another bolus of insulin, or adjusting the insulin doses. For those who are on metformin or other oral agent, unless they are having hypoglycemia, they could depend on hemoglobin A1c for glycemic target. Although, having said that, just it is important to see the if you want to see, like, but you don't need to use it so frequent, to to check for the glycemic target of fasting blood sugar, having the target below 130 and preferably below 110 milligram per deciliter. And the 2 hour.
Once we finish this webinar to all of the audience, they will receive emails from the society. They can register or fill in the survey, and after that they will get the CME hours, 2 CME hours within 5 days. So thank you all. I would like to thank Dr. Abdelghani, Mr. Ayman, Ms. Amjad for their contribution today. Really very thank you for you and for your time, and see you later in another webinar. Thank you a lot for you, and bye-bye.
Thank you.
Thank you very much. Thanks a lot.
Assalamu alaikum.